Hello everyone, I'm Dr. Balamurugan. I'm a pulmonologist practicing for the past 18 years in Chennai. I'm also a professor, Department of Pulmonary Medicine and the HOD of that. And I'm also a director of the Chest and Diabetes Research Institute in Chennai for the past 18 years. And I am on my way to pick up one of the eminent diabetologists in Chennai, Dr. Ramachandran sir. Let's move on. Hello sir, Dr. Balamurugan.
Yeah, good morning.
Nice to see you sir.
Welcome to
Good morning.
Nilangare.
Yes sir, please sir.
I think first time we are meeting here.
Yes sir, true.
This is a very nice place called Nilangare, the East Coast, and I live here for the last about 10 to 12 years.
Oh good sir, okay.
I run a hospital. I am a diabetologist. And Dr. Ramachandran's Diabetes Hospital.
Okay,
in
okay,
Delhi.
yeah.
I also have a clinic in Irmo.
Okay sir, okay.
We also have a foundation for research and education called India Diabetes Research Foundation.
Good, nice to hear that sir.
Lately, I have been involved in an online platform in which patients can see me anywhere in India.
Oh good, okay.
So it's called DiaHome.
Okay.
Patients can download the app in their mobile phone
Alright, okay.
and connect with us.
Sure.
We do the investigations anywhere in India and then consultation with us,
Okay sir.
diabetologist and also the dietitian.
Nice to hear that sir.
So I think it's nice that we are going to have this Roadinar.
Very true sir, very true. Yeah,
Unique experience.
true.
A little different from the usual CME programs.
Absolutely,
I'm
sir.
sure doctors will appreciate,
Yeah,
will watch this because it is entertaining for them.
absolutely sir. It's a
We
different
have a-
kind of platform exactly. You know?
I think it's a combination of some entertainment plus
The
also
scientific
education.
things, yeah. Very true sir. Let's start on with the readiness.
Dr. Balamurugan, this is a road which is very popular in Nilangare where people walk. I also walk here usually in the mornings or in the evenings. Usually it's a very quiet place. But today being a Sunday morning, you
I
can see a little
understand
more
that, sir.
traffic.
It's
and
nice
there
to
is- there'll
see
be noisy.
people walking in the mornings because in my practice when we talk about the sleep apnea, most of the patients would not be going for a morning walk, and especially my patients who already have diabetes and sleep apnea, they usually do not go in for a morning walking. So in your experience, how about what is the incidence of sleep apnea in your patients?
Well, I think first we'll talk about diabetes. I think there is a lot of misconceptions about diabetes. I think we are not, today's Roadinar is actually regarding diabetes and sleep apnea. I would say that diabetes is a silent disorder. Sleep apnea is a noisy disorder.
Very true, sir. But the common link is going to be obesity in that.
Absolutely.
Yeah.
The prevalence of diabetes is increasing all over the world. In fact, in Indian cities, we see about 20% of the adults have diabetes and half of them are not detected.
Okay. Yes.
And if you go to the rural areas, it's around 4 to about 10% of the adult population.
I understand that. Even in my practice, I do have quite some patients with sleep disordered breathing, obstructive sleep apneas, etc. Of which of late I do notice about half of them or more than half of them would be having either a concurrent diabetes right now or they will develop diabetes later on in future. So what do you think could be the most common reasons for this, sir?
I think there is a very, very close association between diabetes and sleep apnea for simple reasons that there is a coexistence of obesity as a causative factor. And it is also known that the incidence of type 2 diabetes among patients with sleep apnea is at least twofold higher than those people who do not have sleep apnea.
Okay.
And one of the best studies has been the nurses follow-up study in the US, which is one of the largest studies.
Yes.
More than 69,000 women who have been followed up, and they found in a period of 10 years, the incidence of type 2 diabetes was double, 2 times higher among people, among the women who had sleep apnea compared to those who did not have sleep apnea. So I've been there in enough follow-up studies to show that.
Very true, sir. In the same study, the nurses study, I think they also said they had differentiated between occasional or the habitual snorers and occasional snorers. And in both the conditions, in occasional snorers, the hazards ratio was 1.5 times, and in habitual snorers, it was about 2%. So that means there are twofold risk of those patients developing diabetes later on in life. So what else could be the reasons for that?
I think there is real explanation why sleep apnea could increase the incidence of diabetes. There is because there is fragmented sleep and also hypoxemia, which is intermittent hypoxemia. There is an increased sympathetic activity with increased catecholamines coming, and then there is increased hypothalamic insular axis, which is increasing the ghrelin levels, and then you have also anti-inflammatory. I mean, the inflammatory markers are high.
So there is a spillover of inflammation,
yeah.
Correct? Yeah.
And you find increased IL-6 and tumor necrosis factor. It's also seen that we also have increased adipokine. For example, in sleep apnea and both in type 2 diabetes, decreased adiponectin is seen. And adiponectin increases insulin sensitivity. So sleep apnea increases insulin resistance and puts a load on the beta cell activity, and therefore predisposes people to diabetes. So there is no question that other than the association of just obesity being a causative factor both for sleep apnea as well as for type 2 diabetes, there is also a direct causative association between sleep apnea and type 2 diabetes.
All right, fine. Yeah, even in my practice, I think apart from the obstructive sleep apnea, most of the patients who are diabetics, already known to be diabetics, being diagnosed of obstructive sleep apnea, I just went through the history, lots of problems. As you said correctly, the sleep fragmentation is one key factor. Because of the sleep fragmentation, they have excessive daytime sleepiness. And because of this excessive daytime sleepiness, it has got its direct as well as indirect effects. Like for example, the diabetics, they forget to take the medication. Because of the sleep fragmentation, they become more tired in the mornings, and there is no motivation for them to go for a regular exercise or walking in the morning, as I can see over here. And because of these factors, the sugar level further gets up. And because of that, on the longer run, they are more prone to develop complications, like for example, a neuropathy, peripheral neuropathy. So in your practice, how do you think the neuropathy is going to affect the sleep apnea, sir?
Okay, it is not only neuropathy, as you rightly said, the presence of sleep apnea in type 2 diabetes increases the risk of high blood glucose because it is more difficult. There have been a number of cross-sectional studies showing those people who have sleep apnea have a slightly higher HbA1c compared to those who do not have. And that is because probably they are having increased insulin resistance. And the other thing which you mentioned is absolutely right. There is a confusion among people with diabetes whether their symptoms of fatigue, weakness, etc. is perhaps due to uncontrolled diabetes or is related to sleep apnea. In fact, I think those people who have severe sleep apnea, most of the symptoms are probably related to the obstructive sleep apnea rather than for uncontrolled type 2 diabetes. The other question is whether treatment of sleep apnea can improve HbA1c. I think there have been a couple of studies showing that. There is a very good Oxford trial where they found a randomized controlled trial showing that those for 3 months only it is done, but a very small group. But however, they found that those patients who have been treated for sleep apnea had a significant reduction in HbA1c compared to those who were not treated. So I think it is worthwhile recognizing sleep apnea as an important associated condition with type 2 diabetes and taking that and treating that to actually also get better outcome in type 2
Very
diabetes.
true, sir.
One of the questions as a pulmonologist I want to ask you is that unfortunately snoring is not considered as an abnormal thing by lay people. They feel a person who is snoring is sleeping very well and happily. They do not know that that is actually an abnormal, it is a sign of an abnormal disorder called sleep apnea syndrome or OSA.
Okay, very true, sir. Most of the patients whom they think the awareness is very low. When I talk about the awareness, it is not only from the patient's perspective, also from the physician's perspective. Most of them, they do not give good care for snoring. One thing, being a diabetic, they are more prone for complications as such, which is independent of the sleep apnea. But when they also have a sleep apnea, which they are more prone to, they are likely to get more complications, especially the adjudicated the cardiovascular and the cerebrovascular incidents or more. So I think right from the beginning, it's a sort of a bidirectional screening. So all the diabetics should be screened for obstructive sleep apnea and vice versa. All the patients diagnosed with obstructive sleep apnea should be diagnosed and treated for diabetes per se. When we think in terms of diagnosis, I think we do have various levels of sleep studies being done. So the phase 1, 2, 3, stages 1, 2, 3, etc. I think sending a patient for a complete polysomnography might not be good at this point of time, I would suggest, because it involves lots of variables. Like for example, apart from a thoracic movement and checking the pulse oximetry and then the nasal flow of air, we go with an electromyogram, electrooculogram, electroencephalogram, electrocardiogram, muscle movements and all the stuff. So if the patient's being sent to a sleep lab, they get frightened by looking at the number of wires and all this stuff. So what I do in general practice, in my pulmonology practice, I check only the respiratory involvement. Like I check only a limited sleep study. So I ask the patient to get this thing tested at their home, because if I admit the patient in the hospital to get the sleep study done, or if I ask the patient to go for a sleep lab, a new place, they might not get that adequate sleep. So I ask them to go and get it done at their home. And I always have the cutoff of based on the apnea hypopnea index. The normal AHI is less than 5 events per hour. Up to 20 we take it as mild, up to 30, 21 to 30 as moderate, and more than that as severe. But trust me, most of my diabetic patients, they have either a moderate or a severe sleep apnea, and then I go with the CPAP titration in them. Lots of studies have shown CPAP is not going to be of that valuable in terms of decreasing the A1C levels, but in terms of, lots of these studies have done only for 3 months to 6 months. We need a longer amount of time for that today. But in my practice, I think most of the patients being started with the CPAP do very well. Most of the patients, if I tell like you need to go ahead with the sleep app, they ask me, doc, I put the mask over my nose or my mouth and then I sleep the whole night. Do I have to live with that lifelong? But the thing is, after a week's time, if I ask the same patient, okay, fine, can we stop the CPAP? They will invariably say no, because the comfort is so good. The quality of life is very good. They would not like to part the CPAP on them. So they like to continue that, and most of the patients are doing extremely well with that. The complications are reduced, not only the cardiovascular complications, lots of other things. But we should understand one basic thing, since obesity is the key in this, target should be basically for decreasing the obesity. If that is not done, there is no point in giving any other form of a treatment apart from the sleep etiquette and the CPAPs. If the weight is not reduced, it is not going to be fruitful at all, sir.
Absolutely right. I think obesity is a common factor both for diabetes and sleep apnea. And so if the people reduce weight and bring down their weight to ideal body weight, you treat both. You can get rid of your sleep apnea and also can control diabetes better.
Very much.
So I think we should be telling patients to do lifestyle modification, which is the most important part of treatment, which can actually cure your sleep apnea completely and also control your diabetes better for lifelong, and then improve your quality of life.
Very true, sir. Lots of questionnaires are available. People can utilize that. Like for example, we take a simple thing like called as a stop bank, where the patient's history of snoring, if they have been observed, witnessed or apnea, you ask the attender if you are able to notice the sleep or the quality of sleep is decreased and the patients have apneic spells. So that is one thing. We check with the neck circumference. Patient is a male or a female, and also the other activities if they have an excessive daytime sleepiness. So we come to a conclusion based on that questionnaire. If the patient is more prone to develop complications of sleep apnea, which is available nowadays, I would urge all the physicians treating diabetes or OSA to utilize these questionnaires and go ahead with that, sir.
Okay. One of the problems that I find is that when we suspect clinically that patients do have obstructive sleep apnea, they are not ready for the diagnostic sleep study because it is so difficult to get it done, and they get scared about the wires and the putting them. But those patients in whom definitely we tell them about the benefits of diagnosing and treating this condition, I think they get convinced. And as you rightly said, once you finish the diagnostic test and then start using the CPAP apparatus, they find the improvement so good that they said, oh, well, I should have done this earlier.
Sure.
I think that's exactly
what. The awareness is also on the lower side, and especially in this part of the world. For example, when we go to the western side like Coimbatore and all the other areas, A-Road and all, the awareness is much more. That they keep doing the sleep studies almost 4 or 5 on a daily basis, whereas here it is very less. The reason is awareness not only from the patient's perspective, but also from the doctor's side also. I do think it is on the lower side.
I think the most important thing is the doctors should ask every diabetic who is especially obese about whether they have snoring or not. And from that should be the beginning of investigations, and that awareness has to be created.
Very true, sir. Very true. I accept that. And it should be the vice versa also, sir. Any patient being diagnosed with OSA, either at that point of time or later on, they could be having diabetes. So for that, the routine checkup with all the other parameters should be undertaken in each and every patient diagnosed with sleep apneas.
Okay, we have been talking about the association between type 2 diabetes and OSA. Now, OSA itself is an important cardiovascular risk factor,
Yes,
isn't
sir.
it?
Yes. So most of the patients with obstructive sleep apneas are more bound to have, as I said, adjudicated CVVs. Like for example, not only the cardiovascular events, but also lots of cerebrovascular accidents. That is basically because of thrombosis. And you know, the basic reason for these patients to have this one, not only the cardiovascular, in that sense, I'm talking about various arrhythmias also. So the basic reason is intermittent hypoxia. So this causes triggering arrhythmic potentials, and not only that, because of the thrombus formation, the patients are more prone for developing myocardial infarctions, especially early in the mornings. So silent heart attacks we call, and also patients are more prone for developing cerebrovascular accidents as well as a peripheral thrombosis. Now, having said that, the common factor in these patients could be a history of obesity as well as smoking, sir.
I think that's correct. I think now you said OSA itself is an important risk factor for cardiovascular disease. Now we can have a combination of OSA plus type 2 diabetes, it actually doubles the risk. There have been very good studies to show that when you have patients with type 2 diabetes without and with OSA, there's a very good Cleveland study, a follow-up of about almost 5 years, about 800 patients, showing that they found that there's a higher risk of heart failure, myocardial infarction, and even atrial fibrillation, as you rightly said, in people with type 2 diabetes having OSA compared to type 2 diabetes without OSA. This is the statue of Annadurai, who is the architect of modern Tamil Nadu. We are standing in front of the library named after him. You're talking about the last part,
The
the
oxidative
stress
stress.
in OSA.
Oxidative stress plays an important role. The basic reason for the oxidative stress in sleep apnea patients would be because of various factors, especially the sleep fragmentation as well as the intermittent hypoxia. And the oxidative stress plays a vital role which goes unnoticed, maybe not only in sleep apnea patients, but for that matter, any other disease, be it diabetes, be it hypertension, be it various lung diseases like COPD, various cancers, etc. So it is pretty optimal for us to identify and then to treat them. Nowadays, lots of antioxidant drugs like N-acetylcysteine are available. So the judicious use of these medications should be brought into
Welcome to my hospital. Actually, we are sitting in the outpatient lobby of my hospital, Dr. Ramachandran Diabetes Hospital.
Nice hospital, sir.
Chennai. Thank you for coming here. And you see, so far we discussed one important point, and that is the high cardiovascular risk for both myocardial infarction and stroke and arrhythmia in people with diabetes who have OSA.
Yes.
But as diabetologists, we are also worried about diabetes microangiopathy, namely retinopathy, nephropathy, as well as neuropathy. And you mentioned about neuropathy. And there is good evidence from cross-sectional studies showing that those patients who have OSA in type 2 diabetes have definitely higher risk of retinopathy, even proliferative retinopathy. They also have found that in a follow-up study, decreased renal function as well as neuropathy. In fact, you mentioned about neuropathy, and there is a connection between diabetic neuropathy and also the ventilatory control and the upper airway disease. So I think the connection is becoming more powerful, and I think the etiological coexistence of these two together is going to be great. I think it is to be addressed
Very true, sir.
very, very aggressively, I think.
Very true. It's vice versa, sir. Why we keep on telling all the OSA patients should be diagnosed with diabetes because of the risk of elevating the sugar levels. And not only that, they are more prone for various hypoglycemic episodes. And why we keep telling the diabetic patient should be screened for OSA is because of by virtue of neuropathy. Two things: it can not only affect the obstructive sleep apnea, as you said correctly, the upper airway, but also the central apneas also, which is much higher in these patients, because the control over the system of the lungs is totally lost in patients with diabetic neuropathy, which should be.
Yeah, I think that also, we also find that because of the affection of sympathetic nerves, and there is also an increased risk of atrial fibrillation and arrhythmia. Even already patients with OSA already have a risk of atrial fibrillation, and when they have type 2 diabetes, the added fact of neuropathy increase the risk of cardiac arrhythmia.
Very true, sir. And not only that, we do see lots of patients with OSA have an elevated amount of insulin resistance, and the reason probably because of the sympathetic overactivity. So in those patients, how do we go ahead with that, sir?
I think, as you rightly said, addressing OSA as a part of the treatment of diabetes in those patients who have OSA must be part of the treatment strategy.
Yes, yeah.
There is no way of correcting the ill effects of OSA just by treating diabetes alone. So one of the reasons for, as I earlier said, of HbA1c not getting reduced, and when you find resistant fasting hyperglycemia, may be undetected or undiagnosed OSA.
Probably, yeah.
I would like that especially diabetologists who are listening to this, tell us about how do you treat OSA in a nutshell.
Okay, so all the patients suspected to have OSA should be screened for a sleep study. If it is a polysomnography, well and good. If not, at least an overnight sleep study where we check, it's called as a limited sleep study, where we check the basic parameters like what is the patient's saturation levels, what are they fluctuating, the thoracic wall movements, and then the nasal flow. So based on that, we come to a conclusion, what are the snoring events, what are the different types of apnea, hypopneas present, and how many desaturating events they're going for. And it is categorized further like less than 90%, less than 88%, etc. But the basic thing is, what is the apnea hypopnea index? As I said, it is usually less than 5 events per hour. If it is 5 to 20, it is mild, 21 to 30, it is moderate, and more than 31, it is severe. Usually for the mild or the moderate or severe, the basic thing is we advocate the patient for lifestyle modification. Like for example, if the patient is obese, overweight, we ask them to decrease the weight, one thing. Second thing is various sleep etiquettes we advise. Patients can sleep not in the flat supine position, and the sleep quality should be better. Like we advocate the patients, if they are smoking, absolutely no for smoking as well as alcoholism. We advise them to have a good sleep in the form of not having caffeine-based drinks like coffees, teas, at least a couple of hours before they go into the bed. And not only that, we advise them to go for basic exercise 2 to 3 hours before they're retiring to the bed. Advise them to use their bed only for the purposes intended for that, only for the sleeping part, and most of them they go lie on the bed and watch the TV. That's absolutely not to be advocated on these patients. So with these good things, in spite of this, if the patients are not having a good control over the sleep, we advise them to go for a cognitive behavioral therapy where the negative thoughts on the sleep and various aspects of life are being taken out. I think our psychiatric colleagues will be talking much better on that. So that is well for all the forms of sleep apnea. Apart from that, if the patients are having a moderate or a severe sleep apnea, we advocate them to go for a CPAP titration. We check if the apnea-hypopnea index comes down from the physician's perspective or objectively. Subjectively, the patients also say the next day they feel much better, the quality of life is good, their sleep problems are off. So it probably suits them. So then we ask the patients to buy the CPAP machine, either a nasal CPAP or oral CPAP, advise them to use it on a regular basis. But general thing is it goes dry, the powerful thing. It acts as a pneumatic splint actually. So we advise them to use it with a humidifier also. But we should understand one basic simple thing is the weight factor should be reduced. If the weight is not reduced in these patients, it goes a total waste. So in the last thing is we advise the patients who have an intractable sleep problems to go for other therapies like a cognitive behavioral therapy, which usually we refer the patients to psychiatric colleagues, they counsel them on that. The basic aspect is the negative ideas on life and other aspects should be taken out of their mind so that they have a peaceful sleep on that. So, apart from these things, specific therapies like a CPAP therapy and then the medications can be advocated in these patients.
I think good sleep is important.
Very
That's
much.
important,
Very true.
especially not only for diabetes but also for good life.
Yes, yeah.
When we treat diabetes, I think it is important to recognize that there are certain anti-diabetic drugs which are specifically good for treating OSA.
Okay.
For example, the two classes of drugs, the incretin-based therapy with the GLP-1 analogs, have shown to have benefits on reduction in weight, as well as it can also reduce the risk of OSA and also the severity of OSA.
All right. Okay.
The other group is the SGLT2 inhibitors. It's interesting that SGLT2 inhibitors also reduce weight, but it has been shown in randomized controlled trial, even before they lose weight, SGLT2 inhibitors reduces the blood glucose, as well as it has got a beneficial effect on the severity and the frequency of OSA.
Okay.
So I think we have to remember, as when you treat diabetes, the incretin-based therapy, especially GLP-1 analogs and SGLT2 inhibitors, have positive beneficial effect in patients with OSA having type 2 diabetes.
Okay.
Anyway, we have come back to our house,
Sure, sir.
my house. So thank you very much for coming
Absolutely,
today.
sir. Pleasure
I
is
think
mine, sir.
the Roadinar was very interesting, and I think the science we try to communicate during this Roadinar will be interesting for the doctors,
I hope so, sir.
because it is not a boring type of CME program. I hope those people who are going to listen to us and participate in this will be benefited by the knowledge they are going to gain regarding diabetes and sleep apnea syndrome.
Sure, sir. I'm pretty privileged to meet you out here, sir. I sincerely hope we'll be having another platform once again to meet, sir.
I know.
Thank
It was
you,
very
sir.
nice meeting you.
Thank you, sir. Take care,
All the
sir.
best.
Thank you.
Friends, I'm Dr. A. Ramachandran from Chennai, and we just finished the Roadinar on a very important topic, which is obstructive sleep apnea syndrome and type 2 diabetes. As you know, both these conditions are lifestyle disorders, and there is a very strong association between sleep apnea syndrome and type 2 diabetes. I think the Roadinar, which will be much more interesting than a usual CME program or a webinar for you people to actually participate, listen and understand. This topic is a very important issue in clinical medicine, and I think all those who attend and participate and listen to this Roadinar will be benefited from the science that we have talked about, both OSA and type 2 diabetes. All of you know that type 2 diabetes is a highly prevalent disease in the population, and obstructive sleep apnea syndrome is another condition which is also prevalent and often missed. And the association between OSA and type 2 diabetes looks to be pretty strong, and there are important factors which can increase the risk of cardiovascular disease as well as microvascular complications in type 2 diabetes if there is a coexistence of sleep apnea syndrome with type 2 diabetes. Therefore, identifying the presence or occurrence of sleep apnea syndrome in patients with type 2 diabetes, especially those who are obese, is important, and treating OSA along with hyperglycemia will give better outcome. And I also told there are specific drugs in type 2 diabetes like the GLP-1 receptor agonist and the SGLT2 inhibitors, which can actually give beneficial effects in type 2 diabetes patients with sleep apnea syndrome. Roadinar is a very interesting way of communicating science to doctors. It is very different from the usual CME programs and the webinars. And I think I enjoyed participating in this Roadinar, and I am sure those who are listening to this will definitely enjoy participating and also listening to the Roadinar, because it is actually a combination of life with science, and I am sure you will appreciate it. Thank you.